This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community, working in legislative, regulatory, and political arenas to promote the free enterprise system. Information at vachamber.com. Virginia hospitals and health systems provide jobs. They support our economy and promote public health. Local hospitals are always open to help people with unexpected health needs. Having a stable healthcare network is vital. Virginia hospitals are our lifeline.
I just received a letter from a student who thanked me for instilling the love of math in him. That's why I teach.
Brought to you by the Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.
Welcome to This Week in Richmond, and a welcome back to two members of the House of Delegates. Been working to get the two of you on, and so delighted that you could be here together. Delegate Bobby Orrock began serving in 1990, Delegate John O'Bannon in 2001. Very much involved in health committees, even though Bobby's a teacher and John's a physician, but Bobby chairing the Health, Welfare, and Institutions Committee, and you're vice chair of it. Appropriations Committee, Finance Committee, both of you on the Joint Legislative Audit and Review Commission. And I will stop right there and not take any more of the time, because it leaves the last 23 minutes to talk about issues that you all see coming up in the 2017 session. Bobby, you're the senior one, so we'll start with you.
Well, of course, the overriding matter is going to be the budget, but as far as the health issues, I think the two in particular we're going to see before the committee. There are a number of measures going to be introduced, I'm sure, relating to the opioid problem, naloxone, those types of drugs, and all the peripheral issues that their abuse has brought within our society. We're going to be early in session hearing what's already happening from the Board of Medicine, Board of Pharmacy, within the department, just so that as legislation then comes to our attention, all the committee will have an understanding this is already happening. And so we might not want to put in legislation that may actually slow the process by having them go through regulations if they're already addressing it, because they know the issues that are there and actually know them more intimately than most of us. Dr. O'Bannon, as a physician, kind of being the exception to that. We are very blessed, one, to be a citizen legislature, but because of that in particular, to have a significant number of folks in the medical profession on the health committee, and not just all medical doctors. We've got a broad spectrum, and so that expertise helps tremendously. The other issue that's been out there for years and probably will continue to some measure for years is the Certificate of Public Need. The underlying policy started back in the mid-'70s, has not been changed radically or even substantively since its implementation. The underlying premise, I think, is still very valid, that we've got to ensure that medical care is going to be available throughout the Commonwealth. And given the population density challenges, differences in availability, we've got to make sure that citizens are going to have the medical care they need in close proximity. That being said, how we achieve that is very much subject to discussion and has been. For the House part, we passed a measure last year trying to reform the current process and build in more competition, where the intent being, by competition, we can still provide the same level of services and hopefully at a lower cost to the patient and greater benefit, maybe even potentially some greater services available in certain areas. The Senate didn't necessarily agree with our objective without throwing more money at the problem, to put it candidly. So therein is where the differences arose last session. We're going to be meeting more between the House and the Senate in the next few weeks to try and see if there's some common ground to go forward. But the issue itself is going to stay out there, and I'm sure is going to consume a fair amount of time of the Health Committee in this short session.
Were you and the other physicians kind of the same mind as the others in the House on the COPN?
So I want to thank Chairman Orrock, who
Yes.
actually knows a lot about health care. He volunteers with the rescue squad, has for
Yes.
many years. And I would certainly agree with exactly what he said. You know, we in this state, in this country, are now dealing with a true epidemic. We're losing more citizens to opioid and heroin overdoses than to car wrecks. And for the first time in many, many years, our longevity rates, how long you live in the United States, didn't go up, it flattened off, it started to go down. Now that could be obesity, diabetes, it could also be that we're losing so many younger folks to this drug epidemic. At its core, the real challenge here is the fact that substance abuse, whether it's opiates or tobacco or alcohol, is largely genetic. It runs in families, and it's a physical condition. It's not a frailty or a lifestyle necessarily. And so what we've done is we've now got all these very strong drugs out there, and your General Assembly tends to be a lot better at reacting than being proactive. So now everybody's rushing to come with their best idea about how to get our hands around it. And so I think the chairman's idea of getting the baseline where we are and then moving forward in Virginia is really a good idea. I also appreciate his interest in the COPN is at its core a government-protected monopoly for certain interests. And my perspective on it has been that I think we could actually, without harming anybody that delivers care, we could get access better and cost down some by reforming the COPN laws as they currently exist in those areas of the state where there is lots of robust competition. So we've been trying to refine this, make it work more efficiently, and I think you'll see us continue to do that.
You know, while neither of you serves on the courts committee, one of the things I hear from a circuit court judge friend of mine in Southwest Virginia who has become a true believer on the drug courts really playing a significant role in helping not just send someone to prison, but to help people get off of drugs. And to me, the remarkable thing is that they're not statewide, that they're not everywhere.
So we've looked at drug courts. There is a history to drug courts as far as the funding, and it's that pattern we've seen over the years where your federal government may come in and help start up something by funding something for a period of time and then pulling back those funds. And so what we've got across Virginia is a patchwork where some of the courts are federally funded, much less so than used to be, state funding, local funding. So there's no question drug courts can be a big part of the answer to this in that arena. But it gets much bigger than that. We're short now on peer counselors, on inpatient detox beds, on our CSB system as you know it.
Yes.
Or if somebody decides I want to get clean today and I walk into a place, having an appointment for 2 weeks later doesn't work. You've got to be able to provide that service right then. So drug courts are part of it, but it's also got to be a much broader package, and that's where we're going to be working.
Right, and that is the support system to make it work so that they don't continue in the habits that have caused them to have the legal challenges. And you've got to have community buy-in from the families. So in some cases it takes a little cultural education.
And it's, am I right in thinking, what I've understood, that it's not just in areas of poverty or great unemployment, that it's in affluent parts of the Commonwealth?
We've got a drug court there serving the Fredericksburg area, and they've done a very good job. If you look at the demographics of the folks who are coming out of that, it does tend to be more of the middle class, upper middle class folks who are having the issues. One of the problems that we see sometimes, though, is just the distance folks have to travel to get the services. And one of the challenges I think we've got to address is the fact that those in the less affluent communities who are having the problems don't have the transportation in order to get to the support services that are available some distance removed from their immediate community.
It's pretty clear that this is not directly linked to poverty or the substance abuse problem is universal, so it's going to be present everywhere. What's interesting is that there are actually pockets or places, many of which are in rural areas like Rockingham County or Culpeper or the Valley, where the substance abuse problem has gotten so bad because when you get addicted to, say, a prescription drug, and then you're truly addicted. And then when that drug gets withdrawn or taken away, then that addict may actually go to the street. And so you have a situation where you may have, say, an elderly person who's broken their hip and winds up being addicted and then goes to the street to buy heroin. And we have lots of examples of that. And it's readily available. And there are places in my county that where the police folks know you can go any hour, 24 hours a day, and there'll be somebody there you can buy it from. And what's happened now is that we're dealing with a situation where the drug dealers are bringing in things that adulterate the heroin, or that they use fentanyl, alfentanyl, which is ketamine, carfentanyl, which is the thing that they use to anesthetize elephants. But these things are thousands of times stronger.
Wow.
And so when you get that laced in your heroin, then you have the perfect storm for somebody actually losing their life by this.
What's the status right now in the Commonwealth as far as one's EMS or law enforcement having something to counteract it while they're trying to rush, I guess, a person to the hospital? How is that working, or how is that?
Well, we made Narcan, which is the heroin antidote. Thank you. Take all the help I can get. Has been available within the medical community to a measure within EMS for some time. We've made it a lot more readily available. Excuse me. The long and the short, if you have a patient with a narcotic overdose and you give them Narcan, you can, for the short term, reverse the effects of that. And if they're suffering from another drug overdose, it does no harm. So from a layman perspective, it's kind of like, okay, we're better off to give them a shot. The side effects of the Narcan are insignificant in the grand scheme of things, and it can give us the time we need to get them to the hospital facility for more definitive treatment and address the rest of the problems. It has helped, but it here again is just addressing the problem after it's arisen. We've got to get it at the root, and that's what I know. There's a lot of legislation coming trying to do that, and we all want to achieve that end, but we just got to make sure we do it in the proper fashion. And you know, when you take a hammer to a small dent, you can make it worse if you're not careful.
Yes. I noticed that one of the subjects on JLARC, Joint Legislative Audit Review Commission meeting today, is one that one hears in all kinds of settings, something about Medicaid. What is the status of Medicaid in the Commonwealth? I mean, we hear that it keeps cutting more money out of the budget in order to do just the regular Medicaid, but what's JLARC looking at on that?
Well, you're on appropriations, and it does deal with the
so
money. You go first.
Let me tackle this one. You can do cleanup on this one. So Medicaid is our federal deal with the United States government, and those monies are 50-50 match for the most part. That means the dollar comes from Washington. We match it with a dollar to take care of people. That is a legacy that came in right about the time Medicare was passed. And Medicaid originally was designed to be a safety net. If you were low income, if you were sick, if you were pregnant, and the federal government puts a lot of rules on that. Medicaid also is the place where folks go when they are frail and old and need a nursing home. And that is substantially an industry, you know, where folks who don't have resources and you can spin down. And so that's sort of a process, and that's the way our country and our society has decided to try to deal with these folks rather than other societies where they try to keep them at home or with their families, and it's just the way we are. Having said that, we spend a whole lot of money on both sides of things, delivering the care. The ACA, the Affordable Care Act, Obamacare, said we're going to expand Medicaid to cover everybody that's low income, whether you're sick or not. And the Supreme Court decision said that's not constitutional. It's too much of a burden on all 50 states. It's got to be a state option, which has gotten us to the situation where for the last 3 years we have declined to expand Medicaid in Virginia. As it turns out, that has been the right decision, because the current Medicaid before expansion is the Pac-Man in the budget. It's already gone up to 22% without expanding, and it's now continuing to risk crowding out of your K through 12 or your public safety or some of the transportation, some of the other things that are important to our citizens. So this report, which your chairman of JLARC heard today, was a very comprehensive review of that Medicaid system in Virginia and some opportunities where we can do better.
Yeah, and the Department of Medical Assistance Services that administers the program has done, I think, a very good job, and the report showed for the most part they have. There are some challenges. They need to get more data so that we can make sure that the monies that are being utilized are being done so efficiently. We're addressing the problems where they need to be addressed. One of the greatest frustrations I'm sure they feel, and I know Dr. Van and I both have felt this as well, is the fact we're constrained by the federal rules. And we have for years felt that Virginia is in a posture, we know the needs of our citizens better than the almighty folks in Washington. Let us focus on addressing the needs of our citizenry in a less expensive fashion and for just as high or a better quality of medical care. But unfortunately, we've gone to Washington a number of times with various waivers, and they've just pretty much summarily, especially since the implementation of the Affordable Care Act, said, no, we're not going to let you change anything. The one exception is Virginia some time back tried to enter into a managed care type of program for these patients. It wasn't managed care like we might know in our private insurance providers, but we are at least now moving into that realm where it'll be more of a managed care system for the Medicaid patients as we have in most of our own private insurance. That brings a little more accountability. That brings also certain cost efficiencies with the focus at the end of the day, how do we provide to the citizenry the same or a better level of care for their actual medical needs, not having abuses from the patients, and do it in the most cost-effective manner. And that's what we're all trying to achieve. The report today shows us some areas that we can be more effective in that within the constraints the federal government has put us under.
And I think it's really interesting that Bobby's hit on a couple of key things. Going forward with the new Trump administration and Dr. Tom Price, who's going to be head of HHS, we actually, I think, have an opportunity to free up some of that federal regulatory constraint and look at ways where we can devolve some of this back to each state to let the state do because state's closer to the people. And so we really feel like we have the opportunity to get more flexibility. You know, Medicaid is interesting, but the Medicaid rules say that if you're going to, you can be eligible for a service, but if you make somebody eligible, you've got to make everybody eligible. So you either get dental or you don't. You get podiatric care or you don't. So it doesn't allow for a real good prioritization of, say, the diabetic folks that might really, where it's a health issue, protect. So there are a lot of federal rules that I think we would welcome opportunities to reduce or go to some other ways to get those fundings down here and give us a little more flexibility in how we use them.
Before our time would be out, we'll let our viewers know that we're having a conversation on a Monday, Friday of this week, about the time they will see this show in some parts of the Commonwealth, and in other parts they'll see it after Friday. The governor will make a presentation to House Finance, House Appropriations, Senate Finance. Without asking if you know what the governor's going to present, but what do you see on other matters that are some big challenges that you will face, particularly on the appropriations side and Senate Finance side, at a time when the revenue didn't meet the expectations?
He has a good analogy.
that I was sharing with the group earlier, that you know, our budget situation is kind of like I've got a date with a frog tonight, and recent revenue projections, maybe a few of the warts are going to be cut off the frog before I have to go out with her, but it's still going to be a frog because any way you look at it, we've got over $1 billion shortfall in what we had anticipated being able to spend in the coming year. And we've got to fix that. The appropriations folks have to find where that's going to, you know, that gap is going to be closed. They're going to be looking to us in finance, where can we generate more revenues? And I hate to tell Dr. O'Bannon here this afternoon, morning, whenever this is aired, I don't see any taxes being raised. I don't see any fees being increased especially. the revenues that we're getting are the revenues they're going to have to work with, because our economy as a whole is in a very shaky condition. It's not growing like we would hope. That's why we didn't have the revenues to the budget. So this is the absolute worst time to be taking more money out of the private sector. We've just got to knuckle down, do what we've got to do. I think one of the key priorities they're going to have to find, though, state police do need additional resources, but when you factor that in, they've got to get more resources there and then make cuts elsewhere. I don't envy y'all's position at all.
So it's really interesting because Virginia, just like your house, has to balance its budget and live within its means. We can't borrow ahead like Washington does. So we have this very good, healthy relationship with our Finance Committee, but our job, Appropriations Committee, is going to be to look at the priorities. State police, state employees, of whom I have a lot in my district, have been disappointed by the downturn. We're way down on sales tax revenue. We're way down on sales tax revenue because folks are going to the internet, and your retail is not there. And so the federal government hadn't passed the Marketplace Fairness Act, which would true some of that up. That's a policy, political decision. We're doing a little better in that the jobs that were so taken away after sequestration from Northern Virginia and Hampton Roads are beginning to come back, but they're not exactly those same $100,000 federal contractor jobs that were there before. So we're not perfect at predicting, but the deficit we have will be workable. You know, we have folks come down and see us with hands out from everywhere. So the needs of people are endless. The resources that we have are finite. And at the end of the day, I'm confident we will be able to balance our budget, satisfy the essential needs of Virginia, and leave town on time.
And the session convenes January 11th and is scheduled to adjourn February 25th.
28th, isn't it?
45 days later.
Yeah.
Maybe it's the 28th.
Yeah.
Hopefully early. We've been able to do that
One
the
day.
past couple sessions by a day or
Yeah.
two. So yeah.
And it goes way back. I'm trying to think, I guess, Bobby, you were here when there was one time that the General Assembly adjourned unable to amend the budget and left it to Governor Gilmore to do.
And that senator's no longer with us, so I don't see that problem reoccurring. So.
Yes. Yeah, so you expect the budget will be resolved before that?
Well, and I'm going to give credit to Chairman Jones for House Appropriations and his Senate counterparts on finance. The conferees are already having, if I understand, some unofficial meetings because everybody knows what the needs are and that we've got to make some cuts. And so they're already doing some work now. And that's one of the things that didn't happen years ago when I first started. You waited until the 11th hour and tried to bring these big differences all to conclusion, and you couldn't do it.
And it's worth noting that we are actually in exactly the same position as when that occurred.
Yep.
Yes.
We have a 2-year budget inside
right.
baseball, but we've already got a working
Right.
budget.
That's right.
What we're doing is amending it or cutting it.
Right.
And if we can't agree between the House and the Senate, and we leave town, it just leaves it all to the governor to do. So we probably would not like that to happen. We would like to have some weigh in on this.
Yeah, thank you for pointing that out because that was certainly true in that time in Gilmore's administration that it was the 2-year budget was in place, but they could not come to some agreement on how to amend the budget. So that will be the challenge. We hear of some fees being proposed to be increased, but you're saying you don't expect that to happen in the...
Last I checked, it's also an election year coming up for the House, and so I suspect that may play
But not,
into some
not
of
for
it.
the other chamber.
So,
Yeah,
well,
right,
but they still have to come through House Finance.
Right.
So.
That's the nice thing about the balance of power in the House and Senate, and actually on our side in the House, on the House Finance Committee and the Appropriations Committee. So, and we have a great working relationship with them, and I think it's to the citizens' advantage.
Closing seconds, something else you'd want to say, encourage the viewers?
Well, just encourage folks to stay engaged with the process. They can watch the sessions online.
Right.
Encourage them to do that. They can monitor legislation online, just enter key words. They don't even have to know a bill number.
Right.
And in that process also stay abreast of changes that happen to legislation. Bill summaries aren't changed until the bill has passed both the House and the Senate. So a bill can undergo radical changes in its language, but the summary stays the same. So you got to stay on top of it throughout, but encourage their participation.
Well, thank you very much, Delegate Bobby Orrock, Delegate John O'Bannon for your service, and thank you for being on This Week in Richmond, and we look forward to the upcoming session.
Yeah. Thank you and Merry Christmas.
Thank you.
This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community. For jobs, the economy, and public health, Virginia Hospitals, our lifeline.
The Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.